early intervention and newborn screening. And they'll examine the relationship between newborn screening and early intervention programs for children with or at risk for disabilities. I'm pleased to introduce Dr. Don Bailey and Dr. Elizabeth Reynolds. Dr. Elizabeth Reynolds is from the Public Health Research Analyst and RTI International. And Dr. Don Bailey is a distinguished fellow at RTI International. Some disclosures are Elizabeth Reynolds has no relevant financial relationships to disclose, but Don Bailey has a disclosure for Janssen Pharmaceuticals with a research grant to RTI International, Travere Therapeutics, research grant to RTI, and travel support, but no honorarium for the meeting. Perkin Elmer provided travel support, but no honorarium for him present at a meeting, and Forge Biologics as a consultant. Please reference your screen for the continuing education accreditation and disclosure statement, as well as the continuing education unit tab on the attendee website. And without further delay, I'd like to hand it over to Elizabeth Reynolds and Don Bailey for their presentation.
Great, thank you so much, Jamie, and thanks everybody for joining us today. We appreciate the invitation and look forward to sharing some information with you, and also to hearing your questions and following up with them. So as Jamie said, I'm Don Bailey. I'm at RTI International. I'll just give you a quick overview. RTI is a very large nonprofit research institute. We're located here in North Carolina where our headquarters are, but we have a number of offices around the country and actually around the world. There's a wide variety of research grants and projects. It's all a grant and contract supported organization. I'll just tell you briefly about my background. So for the first, 20 or so years of my life, I focused almost entirely on early intervention programs. My training was in special education, and I studied kids with disabilities and their families, but the early intervention systems that served them. In the last 20 years or so, I've really shifted my focus to newborn screening, how children with chronic with serious health conditions are identified early. But it has really struck me over the years both the similarities and differences between the two systems, and so that led to us writing an initial paper about that, and then a project. And so we're going to talk about that in just a minute. So I was at the University of North Carolina for most of my career. I moved to RTI in 2006 and been working there since then. So Elizabeth, you want to give say a little bit about yourself?
Sure. Yes, I'm Elizabeth Reynolds. I've been a public health research analyst at RTI now for a little bit over a year. My background is, early child development, but I've also got experience on the patient advocacy side with rare diseases. And I have primarily at RTI been working on this project examining newborn screening and early intervention.
Great. Can you move to the next slide? Just wanted to acknowledge that the funding for this work has been provided by the John Merck Fund. The John Merck Fund is a private family foundation. It's not a part of Merck Pharmaceuticals, although I think originally the money for the foundation many, many years ago came from that. But this is a small foundation that has a very strong interest in disabilities and services to families. And so they've been great supporters of us over the years. They're about to close down the foundation. They're spending out their endowment. So this is one of the last projects they funded. Next slide. Okay, here we go. So early intervention and newborn screening are really two very different programs, and but they really are almost designed for exactly the same thing. It's based on the same assumption that treatment or services for children with special health needs or disabilities has to begin as early as possible to maximize benefits. I think most people would agree with that earlier is better. But how you get to earlier and who gets to earlier are very different in the two programs. So both of them are long-standing state-based programs. very much rooted in state agencies. They're guided by national, some national requirements, but mostly recommendations. They both have very well-established ways to identify children and provide services. There are really big differences in the assumptions and approaches. And frankly, even given the overlap in purpose, you would think there's a lot of interaction and collaboration between the two. Our sense was that, and still is, that the two programs operate in virtually independent spheres. But we wanted to do some work to test that assumption to see if it was true, and also to look at what if children with which children identified through newborn screening might actually be eligible for early intervention, and ultimately we're going to be looking at whether they actually get to early intervention. So I was asked to give this presentation because of the article that I published probably a couple of years ago on early intervention and newborn screening, parallel roads or divergent highways. And this was really the basis of the proposal for the funding for what we are reporting today. It's a free open access article, and I know that if it's not in the chat now, it will be shared with you shortly, and there'll be a link that you can follow straight to the journal or to the article. So I think that's enough for an introduction. I'm going to turn it over to Elizabeth, who's really going to walk through some of the nuances of the differences and similarities in the programs, and then some of the data we found.
All right, thanks, Don. I will quickly give a brief overview of both programs we'll be talking about today. So early intervention refers to the services provided for children from birth to age 3 through Part C of the Individuals with Disabilities Education Act. This federal legislation provides guidance and incentives for serving infants and toddlers with disabilities. The goal of early intervention is to lessen the effects of a disability or delay by providing children with prompt intervention. And intervention services might include individualized family service plans, speech therapy, physical therapy, or special education. So enrollment into early intervention is a multi-step process. Children must be identified as potentially having a developmental delay, be referred to their local early intervention program by a parent, healthcare provider, teacher, or other adult, and be deemed eligible. In most states, eligibility for early intervention is based on whether a child has a documented developmental delay, an established condition that has a high probability of resulting in a developmental delay, or is considered at risk. In contrast to early intervention, newborn screening is a universal public health program. The purpose is to detect potentially fatal or disabling conditions as early as possible to allow treatment to begin immediately. Screening panels vary across states, but all state panels include dry blood spot screening for hematological, metabolic, endocrine, and other serious conditions, a pulse oximetry screening for critical congenital heart defects, and an audiological screening for hearing loss. Even after children with newborn screening conditions are identified and receive appropriate medical treatment, many children could experience developmental delay. Despite the potentially high rates of developmental delays associated with many newborn screening conditions, the frequency and processes by which affected children are enrolled in early intervention is not clear. But the exception here is hearing loss. If a child is identified with hearing loss during newborn screening, the National Early Hearing Detection and Intervention Program, or EDI, facilitates the links between newborn screening, diagnostic evaluation, early intervention referral, and enrollment into early intervention. Conversely, it's not known whether there are national programs, policies, or guidelines to streamline the identification, referral, eligibility, and enrollment processes for the other newborn screening conditions, especially the dry blood spot conditions. So our team, as Don mentioned, at RTI recognized these two programs shared a similar goal: to detect and treat children as early as possible. Yet it was unclear whether and how these programs coordinated or collaborated in these efforts. So we set out to examine these links with 4 projects, and I will discuss the results from the first 2 projects today. For the first project, our team examined each condition to determine the extent it was included on states' early intervention's established conditions list. These lists auto-qualified children for early intervention. Next, we conducted a literature review for each condition in collaboration with 2 specialists to determine whether these conditions put children at a high probability of resulting in developmental delay. And for the second project, we conducted a survey of state early intervention and newborn screening coordinators. We aim to understand the extent the programs were collaborating and whether the program leaders were familiar with the other program. And we are in the early stages of Project 3 and 4. Project 3 is a survey for caregivers to understand the extent children are referred and enrolled into early intervention after a newborn screening diagnosis. Project 4 will aim to create and share a template to rate the potential benefit of early intervention for newly recommended disorders. So as noted, our team started our research to examine the links between these programs by conducting a newborn screening condition review. We wanted to determine which conditions were included on states' established conditions list. Again, these are the early intervention lists that automatically qualify children for early intervention. We searched each state's eligibility policy and counted the frequency in which these RUSP disorders were included. And this table here shows the results of the number of times each condition was included on the established condition list. So on average, each condition was listed 8.4 on 8.4 states lists. And as you can see, there was a range from 1 to 21 states. Spinal muscular atrophy was included the most frequently and was included on 21 state early established conditions lists. Maple syrup urine disease and PKU were the next most frequently included at 19 states. Halocarboxylase synthase deficiency and SCID were listed the least frequently and only included on one state's policy. The state that included these was Michigan, and this was the only state that explicitly said all children with newborn screening conditions are automatically eligible for early intervention. So here is the map that shows how many newborn screening conditions are included on states' established conditions lists. At the time of analyses in January of 2022, 75% of states had established conditions lists. And you can see on this map, there are 8 states with these lists that did not include a single newborn screening condition. 11 states included 1 to 5 conditions, 9 states had between 6 to 10 conditions, 7 states had between 11 and 15 conditions, and 3 states included 16 or more conditions. And this was Georgia with 23, Virginia with 29, and Michigan again, who included all of the dry blood spot conditions. For the 38 states with established conditions lists, on average, they included 7.6 recommended newborn screening conditions with a range from 0 to 34. So after we examined the early intervention eligibility policies, we wanted to know whether each condition should be on established conditions list because they had a, quote, high probability of resulting in a developmental delay. It is challenging to determine probability of resulting in developmental delay for these newborn screening disorders. First, these conditions vary considerably. For some, delays may be related to the underlying pathology of the disease, even after available treatment. For others, it's the medical complexity that might put children at a higher probability of delay. And additionally, some conditions put children at risk of episodic decompensation. Second, the clinical severity of newborn screening conditions falls on a spectrum. This severity may be related to disease phenotype or genotype, responsiveness to treatment, or unknown factors. Individual outcomes are also related to early detection, access to medical care, timely treatment, and treatment compliance. And lastly, the knowledge about the natural history and treatment modified natural history and developmental trajectories of many of these conditions is limited. Studies frequently include very few children and do not necessarily use standardized developmental assessments. And finally, there is limited guidance from early intervention on how to define a high probability of resulting in developmental delay. So our team created this matrix and categorized each newborn screening disorder. We considered risk of delay in treatment-altered natural history, extent of medical complexity, and the likelihood of episodic decompensation. And here we present 3 conditions as examples: biotinidase deficiency, severe combined immunodeficiency or SCID, and propionic acidemia. So children with biotinidase deficiency without treatment can develop hearing loss, vision problems, respiratory problems, seizures, and intellectual disability. Coma and premature death can occur. However, early detection and treatment has dramatically improved children's health and neurodevelopmental outcomes. The treatment is relatively straightforward and very effective. Studies of children who were treated early were found to have no differences in developmental and behavioral outcomes compared to their unaffected peers. We determined that biotinidase deficiency had a low risk of delay in treatment-altered natural history. While it may be appropriate to refer children with biotinidase deficiency to early intervention, especially for children who were not identified early or were identified or treated late, this disorder does not necessarily need to be considered an established condition. Children with SCID present early in life with infection, diarrhea, and failure to thrive, and without treatment, SCID is often fatal in the first year of life. Newborn screening and early treatment have significantly improved survival for children with SCID. However, SCID is a complex medical diagnosis with a high burden. Families and babies must isolate to prevent infection. Treatment frequently includes stem cell transplant, and there's evidence that transplant is related to slower gain in developmental skills and developmental delays for children with SCID. The consensus statement from the Second Pediatric Blood and Marrow Transplant Consortium suggested that developmental delays are likely a result of chronic infections, conditioning regimes, prolonged hospitalization, and isolation from other children, lack of exposure to cognitive stimuli, and significant family stresses. So post-treatment, children with SCID could benefit from specific early intervention services, such as physical and occupational therapy to regain the functional skills after they spent weeks or months in the hospital. Additional services might include speech and feeding therapy because mouth sores, persistent nausea, GI problems, and taste change can result in feeding and swallowing disorders. Lastly, transplant carries a significant risk of emotional and psychological consequences for young children and their family. Cognitive and behavioral interventions and psychological support may benefit children's social and emotional skills. And we determined that SCID is associated with high medical complexity and concluded that it should be considered an established condition for early intervention. Lastly, propionic acidemia is an inborn error of organic acid metabolism. Clinical symptoms often begin at birth or within a few weeks and include feeding, vomiting, low appetite, and hypotonia. Without treatment, children could experience episodic decompensation that could lead to coma or death. Early detection and long-term management have reduced mortality, but have not necessarily been linked to better neurological outcomes. And treatment is not curative, and many children experience developmental, ophthalmological, and neurological complications prior to age 2. So children with propionic acidemia could benefit from a variety of early intervention services. Occupational and physical therapy may support children with movement disorders or hypotonia. Behavioral and psychological services may be beneficial given the prevalence of emotional disturbances, conduct problems, hyperactivity, inattention, and peer relationship problems. Speech and occupational therapy may help support feeding, and given the risk of hearing loss and vision problems, children may benefit from audiological and vision services. Ultimately, we determined that propionic acidemia has a high medical complexity and high risk of delay even after treatment, and recommended that this be considered an established condition and automatically qualify children for early intervention services. So here is the final matrix of the newborn screening recommended disorders. And to place each condition, we conducted a literature review to identify the documented neurodevelopmental outcomes and medical risks. Very few studies had reported on standardized developmental measures, so our literature review summarized studies that documented a wide range of outcomes, including cognitive, physical, behavioral, neurological, speech, special education, hearing, and vision, and learning disabilities. Next, we documented the medical complexity of each condition, and we described the effectiveness and availability of treatment, the treatment burden on children and families, the risk of episodic decompensation, neurological complications of the disorder, and whether the condition was a multisystemic disease. Next, 2 pediatric metabolic geneticists independently classified each condition in terms of risk of developmental delay in treatment-altered natural history, the extent of the medical complexity, and the likelihood of episodic decompensation. And after the initial classifications, all of the authors together discussed each disorder and finalized these presented classifications. Next, I'll move on to discuss the results from our second research project, which was a survey study of state early intervention and newborn screening state coordinators. The purpose of the survey study was to understand coordinator perceptions of familiarity, collaboration, and linkages between these 2 programs. We developed our online survey and emailed it to state early intervention and newborn screening leaders. The survey asked about participant demographics, levels of familiarity with the other program, and about programmatic intersections. 3 open-ended questions asked coordinators to describe current collaboration in their state, the potential benefits of collaboration, and also challenges of future collaboration. Ultimately, we used 69 responses in our analyses, and I briefly went back and pulled the Mountain State data, and we had 10 responses from early intervention and newborn screening coordinators in those states. Here are the mean rankings of familiarity and collaboration on scales from 0 to 10. We asked coordinators to rank familiarity on a scale from 0, not at all familiar, to 10, very familiar. Early intervention coordinators averaged 6.4 and newborn screening coordinators averaged 5.2. Next, all of the coordinators were asked to rank collaboration with the other program on a scale from 0 to 10, and early intervention coordinators averaged 6.5, and newborn screening coordinators averaged 3.1. So here are some of the quotes I pulled from the Mountain State coordinators when asked to describe current collaboration in their state. And you can see there was a range of perceived collaborations with rankings from 0 or no collaboration to 10 or significant collaboration. One newborn screening coordinator who rated collaboration as 1 said, "The newborn screening laboratory does not collaborate with early intervention. I am not aware if our follow-up group has any collaborative effort with early intervention. The physicians are responsible for referring affected newborns to the early intervention program directly. Our follow-up group is usually not involved." Another newborn screening coordinator rated collaboration as 10 and said, "There is a Part C representative on our newborn screening advisory committee. They are valued partners and are accessible and open to partnerships." So here are the results when we ask coordinators to rate their agreement with the following statement. Newborn screening program staff provide families with resources and information on early intervention. For the total survey data, nearly 60% of early intervention coordinators agreed with this statement, while nearly as many newborn screening coordinators disagreed with this statement. Similarly, here are the results when we ask coordinators to rate their agreement with this statement. Newborn screening program staff make the referral of children to early intervention. Similarly, almost 70% of early intervention coordinators agreed, while nearly 60% of newborn screening coordinators disagreed. And these two survey questions highlighted two specific instances that reflect a disconnect between what early intervention coordinators thought was happening and the current reality according to newborn screening coordinators. These results suggest that most early intervention coordinators considered newborn screening to be an important identification and referral source for their program, yet there is a possibility that children are unknowingly being missed for referral. Lastly, we asked coordinators from both programs about the degree to which their state's early intervention program considers their state's newborn screening panel when creating or modifying these established conditions lists. The early intervention and newborn screening coordinators both were variable in their responses. For example, over a quarter of early intervention coordinators said they extensively consider their state's newborn screening panel when creating their established conditions list, but nearly as many said not at all or a little. And this variability was consistent with our review of states' eligibility policies. When asked to describe the potential benefits of collaboration between the two programs, here are some responses from coordinators in the Mountain States. Coordinators suggested collaboration could improve identification, referral, and eligibility processes in their state. For example, one coordinator said that any action taken to ensure children are referred to early intervention when appropriate benefits children and families. Another coordinator said to ensure 100% referral of eligible newborns. And lastly, a coordinator mentioned the established conditions list and said, "We just discovered each other via a meeting set up by the Children's Special Health Program. Our first focus is on Part C's established conditions list." And when asked to describe the potential challenges of collaboration between the two programs, here are some of the responses from the Mountain State coordinators. Coordinators describe both communication challenges and also staffing and funding issues. So ultimately, we recommend that each newborn screening condition with a high probability of resulting in a developmental delay be included on that state's early intervention established condition list and be automatically qualified for early intervention. Once this step is accomplished, the newborn screening program should play a role in identifying and referring children after a diagnosis who could benefit from early intervention services. Additionally, both programs need to establish data sharing policies to understand which children are being referred and enrolled and what services they are utilizing. Although there are challenges and barriers, these specific procedural changes could facilitate collaboration and ultimately benefit children and families. So as always, this was a team effort and we're grateful for everyone who contributed to our project. And I will stop sharing and I think we've got plenty of time for questions.
Maybe I could just make a quick additional comment. I think for me, I was certainly surprised, frankly, by the number of disorders that for which children still needed early intervention services after newborn screening. I think we knew that there were some conditions, but frankly had never done a systematic review of that. And it was clear that there are a lot of children, that newborn screening still leads to children who need, or still identifies children who still need services even after treatment. So, so we think those linkages are critical and critically important, and we're hoping to help facilitate that in the future.
Great, thank you. So if you have any questions, please place them in the question and answer tab on the attendee website. I think that was a great presentation. I loved getting a little insight into how much or how little it's for the coordination between newborn screening and EI is in our region. So the first question we have is, how did or do you recruit participants for your research projects? It says, I am one of the nurses who works with the newborn screening program in Louisiana, specifically the follow-up of presumptive positive IEM newborn screening cases.
Yeah, that's a great question. So we got all of the early intervention coordinators were the Part C coordinators, so that we got their emails through the published Part C coordinator list. And all of the newborn screening coordinators, we tried to email both the the director. I think all the program leaders' names were different, but I think there was a director and also follow-up within the newborn screening program itself. And so we know that there's a lot of clinics that work very closely with that, with the newborn screening program, but we didn't necessarily reach out to them. We worked with the people who work directly within the newborn screening program.
And just to add to that, it's a complicated question. In early intervention, there's a single point of contact for the state, and that person would know all the eligibility criteria and for the most part. And newborn screening, as Elizabeth indicated, you've got the lab, you've got the diagnostic centers, treatment centers, you've got the follow-up program, and you've got the local pediatricians. And so any one of those could actually refer children to early intervention, but we don't know that for sure. And we just weren't able to dig into all the nuances of each of those, track the chain in every state, because in reality, the chain could be very different. They could be labeled certain things. And so we did ask the newborn screening programs whether there was someone else who was more suitable to answer the survey, but we didn't push it down to the regular pediatrician level, which is oftentimes where the referrals might occur.
Thank you. Is there any data on how the children identified in early intervention are doing 10 to 20 to 30 years out, or if newborn screening changed long-term outcome?
You want me to start, Elizabeth?
Sure.
Yeah. So, ever since I started in the field 100 years ago, people were asking this question: is early intervention effective? Right. And so, what do we mean by effective? Are children making better developmental progress? Are we reducing the secondary complications? Are families feeling more supported and able to care for their children in ways that they might have more difficulty? And then in the long run, are children, let's say, more successful in school or in life and more independent and so forth? And so we don't really have good answers to those questions by specific disorders, right? And that's the complicated question. How do you know a child with propiatic acidemia or a SCID or whatever? What's that child going to be like in 25 years? And did early intervention help enable that outcome? Well, of course, there's all kinds of stuff that happens in between early intervention, and there are all kinds of studies on early intervention related to elementary school, or let's say high school outcomes. But so much happens in the intervening years that it's hard to rely on early intervention as the kind of only cure or primary reason for those outcomes. So it's part of a system. So I do appreciate the question, because I think I'll just editorialize one more thing. So early intervention is currently, when the National Committee makes recommendations for which disorders ought to be in newborn screening, early intervention is not considered as a part of the net benefit. It's really more medical treatments. So we're hoping, as Elizabeth said, to help develop a template, not so that early intervention might replace, medical treatments, because I don't think that's going to happen anytime in the near future unless we had a, clear evidence that that in and of itself was a strong treatment. But we're hoping that it could be factored into the overall net benefit equation.
Thank you. Is there a repository available that provides the established condition lists for each state?
Nope, we had to go to each state's lists and manually look up whether these conditions were listed. And some states have detailed Excel documents, some states have photocopied PDFs that you can't look up. So I think that each state has their own, and there's no consistent list across states.
And some of it is more how you interpret it too. So the state might just say, it was established condition is any condition that's likely to lead to developmental delay without listing any of them.
Right.
And then others would have a specific list, and says or other conditions that might lead to delay, et cetera. So, but there's no national repository. We'd be happy to share once these data are we've published it. But a part of the problem is these things are constantly changing.
There is quite a discrepancy.
Sorry, can I just add, there's no national guidance on that. So the federal law only says that this is one of the required eligibility categories as any child who is at risk for or has a high probability of having a developmental delay. It's completely up to states to make that decision.
Yes. Let's see. There is quite a discrepancy between the EI and newborn screening programs. Are we missing that primary care providers may be ones bridging the gap?
Absolutely. I mean, I think that our survey results showed that both the newborn screening and early intervention coordinators believe that the primary referral source was these primary care pediatrician clinicians. I think that even, our recommendation to have a clearer list of who should be referred and identified by having the specific newborn screening conditions listed could support pediatricians in that effort too, because some of these conditions, 2 or 3 kids in the United States are diagnosed a year. And so a pediatrician might not be familiar with that disorder. And so having that established list conditions specifically might be beneficial to the pediatricians as well.
I think it's a challenge for pediatricians in general. They're responsible for primary care of children, and then referral to other services. It's time consuming. How much are you trying to link formally with the program? You're just going to tell parents about it and hope that they find something. I think so. Yeah. So as Elizabeth said, we're hoping that at least the information we have will help be a guide to pediatricians, as that would be another good next step for us.
Right. Can you expand or explain a bit more about SCID? Wouldn't be universally qualified for EI. It's mind-blowing.
About why it wouldn't or why it would?
About how it wouldn't.
So SCID was one of the least frequently listed on established conditions list. It was only included once. And obviously after our review, we agree with that. We think that given the medical risks and the amount of time babies are spending in the hospital and the chemotherapy and the psychological and family burdens, we would think that kids could benefit from early intervention. I don't know why programs are not automatically qualifying SCID.
Right.
It's just such a medicalized disorder right now. I mean, you're really focusing on medical treatments that are life-saving and preventing infection, the deadly infections, that maybe it's not as much kind of thought about the developmental and social consequences of it. That's what we're trying to highlight.
Thank you. Circling back to an earlier talk of today, is there any data on health inequity inequities that may arise for certain high-risk newborn screening conditions and access to early intervention?
That's a good question. So I think with newborn screening, the good thing is that it's universal at the screening level. Every baby born in the United States, almost every baby has newborn screening. A few parents will opt out of it, but 98, 99% are screened. I think what the question might be is then, as you move from that to services, are services equitably received? I think for the most part, the initial, very expensive, high-tech, for lack of a better word, services like a stem cell transplant and so forth, I'm going to guess is pretty equitable, because Medicaid covers those services. The medical emergencies and the clinics will help families get those. I'm guessing that the inequities start to grow and happen as children, move into the regular service system and maybe don't have access as much to regular pediatric visits and so forth. So that's, I think, how it happens in newborn screening, but I'm just, guessing how it happens. Early intervention, a little bit of the reverse problem that, the identification of children requires somebody to notice that there's something not right and refer children. And so the referral part of it could actually have some inequities in it. It may be that because a lot of families have to advocate for their children, say, look, my child does have a problem, and get to a point where they can get into an evaluation for early intervention. There's a long waiting list often for that. So I can see inequities happening there. I think once they're eligible for services, I think it's pretty equitable. Every child gets an individualized family service plan. They should get the services that they receive. So it might be that they need. So I don't know. There are inequities in enrollment in early intervention programs. We know that. So I don't know if that's helpful, but I think there are different ways inequities can happen.
So coming from this study, are there any thoughts on how to bridge the gap between the two, between newborn screening and early intervention, and getting the referrals into early intervention, or connecting the families with EI if it's not coming from the pediatrician or straight from newborn screening to EI?
I think that the established conditions list is a really important first step to develop those relationships. And I think that, we have a couple other recommendations that would help support linked families. I think that, maybe it's a more challenging recommendation, but whether newborn screening program could provide resources or information on early intervention directly to families, or whether they could refer families directly. I think that that's something that is happening in some states, but in other states, that's not happening at all. But I think that would be a way to link the programs. Also, I think, some of our responses from our survey pointed out that coordinators were not even familiar with the name or email address of their counterpart in the other program. And so, maybe a really initial first step would just be kind of starting those conversations, creating shared goals about what the next steps could be, and in order to see, what's a policy that their state could pursue.
Great, thanks. So you mentioned how each program is different, how those the conditions that are standard for referrals to EI is different for each state, and some states don't even have any direct referrals. As far as the early intervention side of it, the evaluation part, since each state has a different whether they get the referrals or not based on the condition. Each state is also different on how they qualify somebody for early intervention. So is there any suggestions also coming from this to facilitate more standardization of that, or I guess opening the door for patients to qualify for services across the region, across the U.S. And
yeah, it's a complicated question, and hate to sound pessimistic, but I think cross-state harmonization of some of these things, if that's what you're asking, I think it's going to be a big challenge. A lot of it is in either legislation that within the state's legislation, or mostly in the rules and regulations within state departments. And they might have, every state right now, for example, for developmental delay, there might be one state that says, you have to be 2 standard deviations below the mean in one area of development. Another state might be we have to have 1 standard deviation below the mean in 2 areas of development, and then all kinds of other variations like that. And so actually the developmental delay classification in and of itself is variable. We didn't even look at that here. Now, the established conditions are ones that are likely to lead to a delay. Some states in early intervention programs, if you're in the established conditions list, you get maybe a more of a surveillance model. There's probably there is early intervention that's being provided for many of those children, but I'm going to guess is that they're going to be watching those children to see if they started to show developmental delays, and if they do, then they start to get more intensive services. So it's complicated. And I think trying to harmonize it around the nation would really require federal leadership that there's not authorization or ability to do that. I think maybe another piece, I don't know if you're asking this, but what's the responsibility of early intervention to reach out to newborn screening or to all babies who are identified through newborn screening and say, hey, look, we're here. We can provide help for you. There are all kinds of privacy considerations there, as well as I guess just technical and communication considerations. And so, but I think what Elizabeth's point earlier is it's all about communication, right? It's about getting the programs together initially and saying, okay, here's how we're working, here's what we're doing, here's what our goals are. How can we make more of a seamless entry for and transition for children who are eligible and their families?
great, thank you.